Okay, hi everyone. So we're going to start talking about diathermy, which is a continuation really of our conversation about how do we heat deeper tissues. So diathermy is one of the modalities that we actually don't have access for in our athletic training room. So you won't have any hands-on activities or any competencies to do with diathermy. So really the purpose here is for you to understand the theoretical kind of background of diathermy, what would our settings and such be, but machines especially change so much with diathermy that you're really going to have to, when and if you end up working someplace with diathermy, you're going to end up having to really pay attention to your specific machine and the instructor's manual and things like that. So what is diathermy? Diathermy literally means in Latin through heat. And so the idea is taking these high frequency electromagnetic waves and trying to heat deep tissue with them. So we talked about electromagnetic waves with eSTEM, and we have similar concept of the production, but we're really focused on kind of the electromagnetic fields and what that does to the tissue and how we create some friction in the cells in order to produce the heat. It's not used as often in the United States as our other modalities. Obviously, we don't have access to that, and there's a couple kind of reasons for that. The first one being that it's expensive. So machines run anywhere from $3,000 to $25,000. Um, with our other modalities so far, our combo units where we can have ultrasound and eSTEM, those are on the lower end of that price range. They're usually around $1,000 to $3,000. So to get a machine that really has more limited purposes um, for that kind of expense usually isn't something that people want to use. Um, there's also a lot of misinformation out there about diathermy. There used to be kind of different type of diathermy um, that caused a lot of issues and contraindications. There's also a lot of concern, even still, with the electromagnetic radiation that the machine gives off. And so the machines have definitely gotten better at shielding that, but we still have a lot of issues about where we can place it, even within our space. We don't want metal too close to it. Um, so a lot of people have just kind of shied away in general. There's also a lack of research on diathermy because of really the other two things, and it's not something that people are really pushing to have research done on. Many insurance companies don't have codes even for diathermy, and most of our treatment is run, by what insurance companies will reimburse. And so if it's not there, and a lot of why it's not there is people don't use it often and it doesn't have the research to support it. Um, those contraindications, like I said, were really worrisome, and people kind of stopped using them for those things. A lot of leaks in the shielding, but like I said, a lot of that has been vastly improved, and it's relatively safe to use now. Most of the studies done were actually done kind of pre-1970s, which is on some of these older machines that had all of these issues. So they're just kind of starting now over the past maybe 5-10 years to really start to see a new wave of research for diathermy. So we have different types of diathermy out there. And again, so the diathermy is the high frequency electrical currents are producing deep tissue heating. And it uses an oscillating high frequency electromagnetic energy, actually similar to broadcast, so like uh, radio signals, in order to produce the deep heat in the tissue. And so there's these different types of diathermy. There's long wave diathermy, which isn't used at all anymore. Shortwave diathermy, which is going to be our focus. And so shortwave diathermy, um, it's regulated by the government, just like radio call signs are, essentially, radio waves. And so there's a couple frequencies that are reserved by the FCC, the Federal Communications Commission, um, to use for diathermy. So 27.12 megahertz at 11 meters is 11-meter wavelength is by far the most common, but there's also 13.56 and 40.68. So just like you would tune in your dial on a shortwave, hand radio, that's what you do for diathermy as well. So it's identical to that shortwave radio idea. Within even shortwave diathermy, we have kind of different ways that we can produce it. We have pulsed shortwave diathermy, which is by far the most commonly used, and we have continuous, which is really only used if you have chronic conditions, and even then we can get our treatment and our heating times with our pulsed. So most current and new diathermy units really are pulsed shortwave diathermy. We can also produce these waves through an inductive form or a capacitive form, and we'll talk about the difference between those. But for one, the tissue that we're trying to teach or reach, I should say, is just affected by the waves. That's more of the inductive, and in the capacitive, the tissue becomes part of the current, just like we would with our typical e-stim. And so we get kind of different results, and we can target kind of different tissue with either form of those. With the microwave diathermy, you put the little sad face here, microwave diathermy isn't used as much anymore. It's a deep heating modality that heats even quicker than our shortwave diathermy, but there were lots of contraindications that come from microwave. And it has also gotten better and improved, but it's still not one that's used, especially in the United States, very often. So again, the kind of focus with the shortwave diathermy is that you can target deeper tissue and a large volume of that tissue. So the larger treatment area, especially, we're going to compare this back to ultrasound a lot, is that we can treat a volume of tissue about the size of like your cereal bowl, versus ultrasound, which they talk about, you can treat an area or a volume, essentially the volume of like a ketchup packet from McDonald's, right? So that's a dramatic amount of tissue that we can target with that shortwave diathermy that we can't get with ultrasound. So our shortwave diathermy is run usually somewhere between 10 and 100 megahertz. Again, these are the three that are typically utilized. The generator produces the EM waves, and also that's where we would control all of our settings is on the control panel of the generator. And then the waves, so the electricity coming through the generator is put through coils. And those coils might be in a drum or in electrodes or in what we call capacitive plates if we're using the capacitive form of shortwave. Or there are some that the coils themselves were in wires, and you would actually coil it around the body. Your book shows a picture of this. But there's a lot of concern with your spacing and how close you have those coils together because of how they produce the electromagnetic waves. So we don't use the wires very often at all with shortwave diathermy anymore. So it's usually either the drums or the plates or the electrodes. But what's in there is one or more flat spiral copper coils. And so from reviewing your videos that you should have watched already, as the current flows through those copper coils, an electromagnetic field is produced running through and around those coils. And so that wave, that electromagnetic field, is what is going to create the heating in the tissue and the non-thermal effects that we also see. The sizes vary from manufacturers. You can have multiple drums. You can have kind of two drums that go on either side of the maybe the joint or the body. Again, you could have the capacitive plates where you have to have two of them, like you would have to have for electrodes. It just depends on kind of your manufacturer, your machine, and the size of the area trying to be treated. But essentially, except not at all, because we're dealing with electromagnetic waves and not sound waves. But if you visualize, especially the drums, as kind of that giant ultrasound transducer, It's what's producing the energy, and it's transmitting that energy into the tissue. So here's some pictures of diathermy machines. So these are the inductive drums. This one is a capacitive, the capacitive plates, but these are the inductive drums where the coils are inside the housing of the drums. And so you place them over the body. They don't actually touch the tissue. There's usually a little space there. And the energy gets produced inside and again transmitted out. But we don't need like gels or things like that like we needed with ultrasound. It can be stationary. So we don't need that like we did for, we don't need to be moving the head like we did for ultrasound. These are more of the newer brand. You see these a lot. These are Chattanooga ones. These are probably the most common new diathermies that you can see. But this kind of shows you again where you plug in some different, the electrosurgical generators that you get for diathermy. So how does it work? It takes the 110 volt electricity, so just again plugging into kind of the wall. And then the generator takes that AC current, the 60 hertz, and converts it to the radio frequency. That radio frequency is applied to the coil, okay, and then a fluctuating magnetic field is generated around the coil, okay? So review back onto the electromagnetic production videos at the start of this chapter. The radio frequency then exits the drum, and the oscillating magnetic field is produced in the body. So that's specifically closer to the inductive, what happens with the inductive. With the capacitive plates, we see what's happening over here where actually, so the coils are inside, okay, but it's a lot like our e-stim where we have to have the two electrodes so that we create the current inside. So then the electromagnetic waves are created in the body versus just affecting the body like the inductive does. So within the body then, kinetic energy, you take the electromagnetic waves are transferred, that energy is transferred into kinetic energy, causing movement of the molecules, specifically a lot of this dipole action. So within the cell membranes, we have a positive side and a negative side of the molecules making up the cell membranes, and they spin and kind of orient themselves so that the negative, especially with the capacitive diathermy, that the negative lines up over towards the positive pole and the positive line up towards the negative pole, and that opens up different channels in the cell membranes and affects cell membrane permeability. Also creates eddy currents, which are kind of these counter currents of, you know, if you've seen a stream running, right, and then it gets around a rock or a little corner, there's usually these counter currents that are produced. That's eddy currents, and they're created in the tissue. And that is going to result in the movement and the friction that's going to cause our deep heating, as well as the other mechanical effects that we would consider our non-thermal effects. So tissues kind of high in electrolytes respond best to that magnetic field and produce a lot of the heat. So the two different types, the capacitive and the inductive, are really going to actually target kind of two different types of tissues. So when we're trying to actually put the current through the tissue, like the capacitive, or when we're letting the electromagnetic field affect the tissue, like the inductive. So this is explaining kind of those two differences here. So with the induction, we get that high frequency alternating current flowing through the coils, producing the electromagnetic field, and that radiates away from the drum or the cables or whatever we're doing from those coils. Again, usually this is now done through drums and not usually through cables. The EMF arises perpendicular to the drum or the cable, and that causes ions to oscillate, and then as that creates those eddy currents within the tissue. So muscular tissue is selectively heated over adipose tissue. So it tends to pass through the adipose tissue and affect the muscular tissue more. But the distance between the eddy current or the coil, okay, in the drum, the inductive drum, and the tissue will decrease the strength of the field. And so the more adipose tissue you have, the weaker the field is going to be by the time it reaches the muscle, but it does not selectively heat the adipose tissue like it would. So the adipose layer affects the treatment, but it does not absorb the energy necessarily. It's the fact that it's taking and increasing the distance. So our inverse square law, right? As we create that distance away from the energy source, we lose our strength. Now, capacitive, the patient tissues are placed between two electrodes, and the shortwave diathermy's electrical energy conducts within the tissue. So the flow of electrical energy passes through the tissues as our typical series circuit, and the tissues act as the resistors, just like we talked about within our E-stim. And then as it goes through resistors, it's going to lose some of its energy to the friction and produce that heating there. Now, tissues that present the most resistance, such as adipose tissue, end up producing the most heat with a capacitive shortwave diathermy. And again, this is where that dipole effect, so the molecules are going to rotate and and they're going to line up opposite of the direction of the charge, and that rotation causes friction for the heating as well as affecting the cell membrane permeability. Now, because we're in a series circuit, we're going to get those, and then parallel circuits within as well, we're going to get those paths of least resistance. And so it tends to, again, really affect adipose tissue and skin more than our deeper tissues. But we get enough heating up in those areas that we get conduction, transfer of the heat, down into the deeper tissues eventually. So it's just different ways. We're still trying to target usually the same tissue. It's just one, we heat the adipose tissue, and then that through conduction heats the muscular tissue. And with induction, we kind of go through the adipose tissue and directly target the muscle. But again, the adipose tissue, how thick that is, still ends up affecting our treatment. So for pulse shortwave diathermy, which is, again, what we're going to use most often, we produce non-thermal and thermal effects in the deep tissues. So the alternating current that is being produced inside the generator that is then going out into the coils, and the electromagnetic wave that creates, again, kind of looks like our sine waves that we talked about with E-stim. And that gets interrupted at regular intervals based on the on-off time of the pulse shortwave diathermy. And that is what's going to affect the amount of heat that we can produce, how we set those pulses, as well as that creates those burst trains. So just kind of like we talked about with like burst mode 10s, and really our IFC and kind of pre-mod, where we create those burst frequencies is what we end up setting. That's what we end up doing with our pulse shortwave diathermy as well. So we set pulse width or pulse duration similar to how we did for E-stim. We are usually somewhere between 20 and 400 microseconds. And then there's usually pulse interval that is preset with the machines to create those burst trains. Our pulse rate or our frequencies are somewhere between usually 10 to 800 hertz. And then we also look at kind of the total power, the average power. And so with our shortwave diathermy, our parameters kind of line up. A long pulse width, so up here near the 400s, and a high pulse rate, so a high frequency, maybe up near the 800s, is going to produce more power. And more power means more heating. Versus having a short pulse width and a short pulse rate, and that's going to end up producing little power, which is going to be closer towards our non-thermal effects. Again, continuous pulse wave diathermy isn't really used all that often because it can cause too rapid and too much heating. Again, if people do have it and access to it, it's really only used for chronic conditions. But most of the machines nowadays are using pulse shortwave diathermy to do non-thermal effects and thermal effects. So unlike with our ultrasound, where whenever we were pulsed, we were thinking we wanted non-thermal effects. In this case, the machine is always pulsed. It's just how much energy we produce. So high frequency pulses get applied to the body. And again, the pulse width is usually short with the power up to about 1,000 watts per pulse. And that results with our percentage of on time. And typically that time is actually shorter than the off time. So kind of like when we were setting up our muscle re-ed and we only had it on for 10 seconds but off for like 50, in a much shorter, we're talking within microseconds here of setting up these pulses. Our on time is actually much shorter than our off time. And it's all about that power produced. So again, we can get thermal and non-thermal effects from this. So anytime our average intensity ends up being less than about 38 watts, we would be getting non-thermal effects. If we get that average intensity above 38 watts and we're using high pulse frequencies and usually high pulse rates to do that, we're going to get tissue temperature increase. And so usually with higher power and a little bit longer of a treatment time, we get those tissue temperature increases, similar to we have for ultrasound, right? The different layers, if we want 1 degree increase or 2 to 3 degree increase for our moderate or 3 to 4 degree increase for our vigorous. But treatment times typically last about 15 to 20 minutes. So to look at our ultrasound versus diathermy comparison here, and this is a nice little chart for that. So diathermy can give us, through the electromagnetic radiation, a larger volume of tissue. So again, about a cereal bowl size versus a ketchup packet size for ultrasound. The target tissue for ultrasound is usually collagen rich, so it was our tendons and our ligaments and the fascia. For shortwave diathermy, if we're using capacitive, it ends up heating the adipose tissue in the skin, but then we can target deeper with conduction of that heat away from that adipose tissue into the muscle. Inductive, it's going to target muscle, blood vessels, nerve tissue more specifically, but again, it is affected by the layers of adipose tissue, whereas ultrasound was not. Okay. The temperature increase, so at 1 megahertz, we got up to maybe 6.3 or 3.5 degrees Celsius, maybe up to 4 to our certain depths. 3 megahertz, we got up much higher. Again, with capacitive and inductive, we get a little more heating available, and that's mainly because of that large volume. So we can heat up such a much larger volume that the temperature will actually increase a little bit more significantly as well. So we see those higher temperatures that we're able to reach. And then because also we have such a larger volume being heated, we have a much longer heat retention. Okay, so the heat lasts about 2 to 3 times longer, which also means that then our stretch window is 2 to 3 times longer than it is for ultrasound. So we have a little more time after the diathermy to put the person on some stretch or do some joint mobs that we're going to talk about next week, or do some traction or some other things to help increase the elongation of the tissue. There's no gels, no cupulants, so it makes it a little bit cleaner than our ultrasound. And it's usually less time intensive for the clinician, though it's really important that you stay and supervise the application because of all the restrictions with the metal. But you don't actually have to be sitting there moving the ultrasound head like you do with our ultrasound.